Ashley, do you mind texting Kim and Dr. Little to see if they're having technology issues for me? You're muted again, sorry.
Dr. Little actually downstairs from here. He just joined.
Okay, okay.
And Kim, I'll text her right now for you.
Thank you so much.
No
Oh, there
problem.
he is. Hi, Dr. Little, thank you.
Hello.
Thank you for joining us, everyone. We are just waiting a few more minutes before we get started. So hang tight and we will begin soon. Thank you, everyone, for joining us. We are going to begin in just a couple minutes, so if you don't mind being a little bit patient, we are almost ready. Welcome to the Wenatchee Valley Museum and Cultural Center's Social Justice Community Forum series. I'm Ashley Sinner, the Outreach and Public Relations Coordinator. Today we are discussing the racial and economic disparities in healthcare that are contributing factors to higher morbidity and mortality among those with lower income and Black, Indigenous, and people of color as compared to white Americans. These disparities have a dual impact. Not only are they resulting in differences in the actual care and treatment that COVID-19 patients receive, but they also put people in Black, Indigenous, and people of color communities at higher risk of contracting COVID-19 in the first place. Today, we have Spanish translation provided by Joe Cortez with Claris Languages. If you are logged into Zoom, you have the option of listening to the translated audio channel. You can do this by clicking on the icon of the world and selecting the Spanish option. Joining me on the panel today are Kimberly Steensma, ARNP, Columbia Valley Community Health, Dr. Ashley Simpson, D.D.S, Dr. Perry Little III, General Dentist, Donnie Guerrero, Community Engagement, Molina Healthcare of Washington, Dr. Bindu Nayak, MD, Endocrinology, Co-Chair of Health, Equity, Diversity, and Inclusion Council, Confluence Health. Dr. Mabel A. Bodell, MD, Nephrologist, Transplant Nephrologist, Co-Chair of Health, Equity, Diversity, and Inclusion Council, Confluence Health. And Keith Howard, Attorney, Northwest Justice Project. Thank you all for joining us. Before we begin, I want to remind the panelists to speak a little bit slower than your normal rate to help out our translator. If you are joining us live and have questions for the panel, please submit them through the Zoom Q&As or chats located at the bottom of your screen. If you're on a mobile device, these are available at the top of your screen. If you're on Facebook Live, please submit your questions in the comments. Our staff will do our best to address as many of your questions as we're able to. After the session is over, we will provide links to additional resources on our website. All right, so for my first question, I would like to ask, nationally, we know, we hear that there is racial disparities in healthcare, and I am wondering, are we seeing those here in North Central Washington? Is that statistic that we hear nationally, does that hold true here where we live?
Hi, everyone. I guess I will go ahead and start off first.
Thank you.
I'm Donnie Guerrero with Molina Healthcare. So I will not go ahead and be able to speak to all parts of North Central Washington, but I was very recently privileged enough to go ahead and join Eduardo, who is running for one of the elect seats, but he went ahead and put a bunch of community rallies and peaceful protests across Grand County. One of those protests is coming to Wenatchee next Saturday, but I was able to join him for 2 of those. And from what I was able to go ahead and get from him is that from some of the bigger cities, there was a lot along the parade, the route that they were taking. There was a lot of, giving the thumbs down, calling people out inappropriate names to the marchers, giving them the middle finger. So even though we are out here in a very secluded part of the state, we are still experiencing it, especially just because I think a lot of folks don't figure that the people of color would be enough to go ahead and vouch for ourselves or speak up. But unfortunately, it is out here.
Well, I want to say that we know that nationally, health disparities have existed for a long time in America. There's been decades of research that shows that. So one of the things that we're doing with our Health Equity, Diversity, and Inclusion Council is really to look for data to see when this is happening in actuality. So that is something that we're working on at Confluence Health. But COVID-19 has really highlighted, immediately right now, the extent of this health disparity. So do health disparities, have they already existed? Yes, we know that they exist. It's just a matter of finding the data for it. But we know that there is data nationally that shows that there are tremendous amounts of health disparities in multiple different categories, and in maternal mortality, in cancer deaths. We also know there's recent data. As an endocrinologist, I can say that there has been data showing that for diabetes care, there in the U.S. there is a tremendous amount of disparity as far as who is treated with the best medications, and people of color often aren't.
You're muted, Dr. Simpson.
We did. Okay. I actually wanted to add to that. So of course, looking at this from a national point of view, the data already suggests that Blacks are 4.7 times more likely to be hospitalized and 2 times more likely to die from COVID. And within 42 states of America, Hispanics and African Americans have more confirmed COVID cases than their white counterparts. And this is something that we really have to evaluate, because the African American population only represents 13% of the US demographic. So with that being said, for us to be the majority of people who are not only contracting COVID, but also dying from that, it shows that there's a disparity. And going along with what was just stated earlier, the research really needs to be inclusive. A lot of times when research is done, it doesn't include a lot of people of color. It doesn't include a lot of the Hispanic or African American population. So when we decide to collect data or do research, we really need to understand and look towards things to help our people.
I'd also like to add that, just to bring it to North Central Washington specifically, minorities in general make up a majority of the workers that are essential. They do those service jobs, those healthcare jobs, those jobs that you actually have to show up and be there in person, and you can't call out, you can't work from home or anything like that. So you are constantly exposed to, you're put in situations where you're going to be more likely to be exposed to the virus. In North Central Washington specifically, you have your agricultural workers who are, the rate among them is a lot higher than the rest of the population.
I'm not cutting off this conversation. I just have to interject and remind us that we need to speak slower, because we do have a translator trying to keep up with us. So we can slow down and keep going. Did anyone else have anything to add to this initial question? I'm not able to hear you, Dr. Bodell. I see you're speaking. Mm-mm. I can't hear you. Mm. No, still can't hear you, unfortunately. Well, we can come back to that if we can hear you in a minute here. Sorry about this. I guess we've talked generally about it, but can anyone enlighten us on like specifics, or like why would there be health disparities other than I get people of color working in more essential jobs that would be more exposure, but are there other reasons why they experience different treatment once they get to the hospital?
I think this question relates to social determinants of health. So we know that social determinants of health can explain why there is an increase in this disparity for certain populations. So the social determinants of health are our working and living conditions, and that greatly affects our health. So working conditions where you cannot socially distance, when you're working in close contact with other people, oftentimes those jobs, there's no other way, you can't get around that. Living conditions where there are multi-generational families in one home or in close quarters, that increases the chance of acquiring COVID-19 and coronavirus. So those are social determinants that do increase the chance of acquiring the virus. And that definitely is affecting the health disparities that we're seeing.
Yeah, and I would definitely agree with that. But I think there are a plethora of other things. I mean, just by even saying, oh, getting treatment when you get to the hospital, that's already something that we've overlooked. A lot of times, there's a lack of transportation. A lot of people don't have access to transportation in order to get to the hospital. And that's why I've been seeing in a few states, they've actually been setting up mobile vans for testing where they're driving into these communities. And in these neighborhoods where a lot of people who are either African-American, Hispanic, they tend to live in close corners, not just within the house, but also within a neighborhood. So you're going into areas where, again, people have lack of transportation. There's a lot of, it's very densely populated areas. And another thing to consider in regards to the disparity of healthcare is the lack of childcare. Parents who are single parents and have children, how are they supposed to go to the doctor when some appointments don't allow you to bring your child? And if you do bring your child, you're also allowing them to be exposed to COVID and other things. So there's so many things that we have to consider before we can even get to see a doctor or a physician. And then as we stated earlier, getting time off of work. A lot of the jobs that people have, they're not able to get time off. A lot of these people are living check to check and also are unable to get any form of health insurance. So they have to pay for these things out of pocket. And then going back in history, you know, a lot of the Black community actually lacks a lot of trust in the healthcare system because there's been ample amount of times where, you know, the Black population has been taken advantage of. For instance, with the Tuskegee experiment, what happened was there were African Americans who had syphilis, and these were military men and other Black men in the area, and they had syphilis, and the treatment for syphilis was penicillin. They decided to allow these patients to go untreated and not provide them penicillin, but continue to see what happens as a result of having syphilis. And this experiment went on 20 years after penicillin was discovered as the treatment for syphilis. So again, just culturally, it's really hard for some people in the Black community to have any form of trust in the healthcare system. And then of course, to actually get there is a huge struggle. Another thing to consider is the language barrier, communication barrier. You know, if a lot of people lack certain education, the way that they speak might not, you know, they may be intimidated by educational or healthcare jargon. And of course, the Hispanic population, if we don't have translators, how are they able to express their symptoms or anything that's going on?
Thank you. Those are good points.
To follow up a little bit on what Dr. Simpson said, I think even today, you know, the Tuskegee experiment was quite some time ago, but even today, I think it's shown that doctors deal with pain with Black patients differently than they do with non-Black.
Black and Hispanic.
Exactly, exactly. The other thing, and Dr. Simpson talked about transportation, but we have thousands of H-2A workers in our community right now, and they are beholden to their employer for transportation. And so, and there's also this disincentive to say I'm sick because they can be sent home because they're sick. And so it makes it very, very difficult for these folks to even get to the doctor in the first place or even ask for help.
These are
I
a
just
lot
want
of
to say,
very, go ahead,
you can-
Dr. Little.
Okay, I just wanted to say more anecdotally, most of the jobs that I had prior to dental school were like that, where there were no benefits, yet they'll give you 40 hours, you work full time, you may work 60 hours, but they designate you in such a way that they don't have to give you any benefits. And once you're in that designation, it's very difficult to take any time off or to call out sick, and they'll just fire you. And, you know, you're expendable. So, cause they can just hire somebody else in there and, you know, you'll be, you know, so if you do become sick, if you do, you know, if you do become positive with corona, there's a high incentive for you to deny it, to try to cover it up, to go to work sick, because that's your livelihood gone just like that. If you, hey, I want to go to the doctor today. Well, that's too bad.
Adding on to on expanding on what Dr. Simpson had gone ahead and said, and also Mr. Howard, just from my colleagues around the state, for the Spanish-speaking population, a lot, especially here in North Central Washington, where everything is so vast and rural, when they do come in, there is a lack of information getting to them. So it's internet access, or maybe they do have internet access, but a lot of the information targeted or being sent out is not in their language. So it's been said, just from colleagues, from what I've heard, is that a lot of the Spanish-speaking population are saying, oh, COVID-19 is not a worry for me because it's a Caucasian problem because it's only targeted to them. And we know that's not the case. So there's a lot of missing parts to this here.
I know that Dr. Bodell and Dr. Nayak have done some work. I read in the newspaper article about, can you tell us what you started doing earlier this spring to overcome that gap?
And I'm going to let Mabel talk about this. Can we, how's your sound, Mabel? I don't know if we can hear yet. Looks like no luck with that. So now Dr. Bodell has done a lot of outreach by radio and through the Chelan Douglas Health District. She's made wonderful videos on social media that everyone has enjoyed about education in Spanish about coronavirus, and that has been really really great. And there's been multiple, and Donnie, you can speak to this too, about all of the outreach that's been happening in Spanish.
No, certainly. And I went ahead and recently reached out to Dr. Bodell a little while ago, just because I do remember her like right from the beginning. She was putting out a lot of information via her Facebook page, and I know she is very active out there in the community. So I agree. And right now we are trying to work. I reached out to Dr. Bodell as a part of the Latinx advisory group from the Chelan Douglas Health District. We are trying to find professionals in the region that are already recognized for the work that they are doing. And we are trying to go ahead and, at this point, just break down that main information into something that is smaller, easier to digest, simple to understand. And we want to go ahead and get that delivered from those professionals, like a lot of you on this panel here today, where everybody already recognizes you and will recognize all the work that you are doing. Because I think it would be a lot more beneficial than from hearing folks that they might not hear from on a regular basis.
Does anyone have any personal experience witnessing or seeing the health disparities here locally in North Central Washington? Something in healthcare recently or not? Can you share with us your experience in seeing this play out?
Well, I can say that I've had in the last few weeks. There's definitely been more in my outpatient practice. I've seen a lot of patients who have recovered from having coronavirus in the last few weeks, more so than any previous month. There have been some stories where some people have even said that they did believe that it was a hoax before they got it. And then they may have gotten it from a family member who was an agricultural worker, and the whole family had it. And then now, they want to spread the word that this is not a hoax. They were very sick, their family was sick, but I think there is this widespread belief among a lot of people that this is still a hoax.
So I recently had the privilege of working with the outreach teams with the Quincy and Moses Lake clinics. And I was very fortunate, and we're very lucky to go ahead and have them out there because they are doing in-person trainings for when those H-2A and agricultural workers arrive here. They are doing like the basics on how to wash your hands and how to wear a face mask appropriately. But expanding on what Dr. Nayak had gone ahead and mentioned, is that they are not getting the information from like the cities that they are leaving when they are first arriving here, and when they are arriving here, unless they are making contact with these health workers initially, they are not getting that information, or unfortunately, or until it's too late, or that information is not available in a language that they can easily read, or maybe for those folks that might be illiterate, they're not getting that information at all. So it is very vital, and unfortunately right now, there's not a lot of that outreach going on in the community either.
So obviously, locally, we have farm workers. So Ken, we touched on it a little bit, but Keith, can you let us know, like, if you know, how are the farm workers being affected? Like, what is the big concerns when it comes to farm workers and COVID?
Well, of course, there are two different types of farm workers that live here locally, live here year round, and are farm workers, and then H-2A workers who come in with contracts with particular employer and are just going to work for a set period of time. There was a suit brought in Skagit County earlier this year when COVID started about the rules surrounding H-2A workers. And as most of us know, in different industries, oftentimes the rules that affect the industries are written at least with a lot of input or a lot of influence by the industry itself. And so the suit had to do with how workers were going to be housed, whether bunk beds would be allowed, and things like that. The suit failed. And so now the rules say for H-2A workers that they have to be in cohorts or groups of no more than 15 workers. And that means housed together, working together, and transported together. When we talk about these H-2A workers, they're not like foreign to us. They're part of our community when they're here. They come into town, they shop, they go to the laundromat, they do everything that we do in town. And so the question is, are the rules being followed necessarily? And I can't give you any, I'm not going to give any anecdotal evidence, but if you see a busload of folks at Walmart, and if there's more than 15 people in the bus, it's likely they're not following the rules. And so that's what it is. And it's unfortunate. We see the two H-2A workers that died, not in the hospital, not getting medical care, but died in the farm worker housing itself. And I know they've set up these quarantine camps for people who test positive for COVID. And I mean, according to the newspaper, and this is just what I read in the newspaper, they check them twice a day. well, one of the workers was dead the second time they checked. And we're all human beings, right? We all have the same rights. It just, we can't just discount these folks that deserve the same health treatment, the same care as us. And so that's what we've seen. I know my office does outreach to these workers camp, and I'm not a farm worker attorney necessarily. I don't work in the farm workers unit. I work in the Wenatchee office. Well, sort of the Wenatchee office, my back room. They know a lot more about it than me. You know, it's the rules are there, but the question is, are they followed?
Do we have any ideas on how the community can support farm workers and the Latinx and Black community, indigenous communities here locally? What can we as a community do to support them?
I think that us talking about this right now is already great. You know, the fact that we're able to have these discussions as well as allow these conversations to have translation is a wonderful thing. I think, I know CDCH was doing a lot of taking their mobile unit, and they were doing a lot of testing at a lot of the locations where the farm workers were. So just making sure that we're providing testing for the farm workers and making sure that we're educating them with these simplified pamphlets, brochures that are translated, and just making sure that we eliminate the idea that coronavirus is a hoax and just continue to educate them on what they can do in order to avoid catching coronavirus. And I think all in all, and this is just not for farm workers, but for everyone, is understanding that this systemic racism and inequality is something that has gone on. It's all of America's history. And, you know, a lot of this is not because of poor choices that people are making in their daily life. These are circumstances that are beyond some individuals' control. Some people are put in these situations because of America's history. And I'm just glad that we have the time today to discuss that and, you know, talk about different solutions in order to eliminate these disparities. And I think, as I stated earlier, just making sure that we have more research, we have a lot more data and inclusive research that's specifically looking at farm workers, that's specifically looking at African Americans, instead of just using, you know, white people and another thing to keep in mind too is with ads. Whenever we put anything on the TV, we need to keep in mind that when we're showing different cases of coronavirus or people who are affected, that we show a plethora of people, not just one type of person that could be affected. And hopefully that could eliminate a lot of the ideologies that are associated with that.
I also think that workers need to be informed of what their rights are and how to be safe at work. And as Dr. Little talked about earlier, it's not just farm workers, it's retail workers. And we see what happened here in Wenatchee at the Walmart. And these people are frontline essential workers. And it's probably not a coincidence that they're frontline workers, but they're also the lowest paid workers. And so the folks that have the least amount of resources to know what their rights are. And so I think it's up to us to let folks know that they have rights to protect themselves.
Could you hear me now?
Yes.
Yes.
Yes, finally. My apologies about that. I don't know what happened with my audio. I just lost it, so I'm on the phone. Just from the perspective of Latina, so my Latinx community usually have a hard time going to the doctor in general. So we don't go to the doctor unless we are really, really, really sick. That's the only time that we seek medical attention. So that's also is part of our culture. So seeking help is not really part of what we know. And that's also part of the gap that we're trying to really break so in the community, that we need to seek medical attention. So before we really sick, because some of these workers who tested positive for coronavirus and they may follow the quarantine. So sometimes they are not feeling very well, but they will not say anything. And even before they get tested, if they have symptoms, yeah, they may continue to push through, to continue to work, just because that's really the work ethic that they have. So that's part of our Latinx culture. So, as I said before, going to the doctor is just not a common thing for us. So education, and more education, and really culturally sensitive information, meaning that, as other panelists referred before, really how we present the information. The information is out there. We just need to be sure that it gets to all of our community members, and how we do that. And that's what a lot of the local groups are doing. So try to really get information to all the essential workers, our Latinx community locally.
I just want to add to that and say that applies, I believe, to the Black community as well. It's the same thing. We don't go to the doctor, particularly for Black men. Don't go to the doctor unless it's really severe. And I think that has to do with more so the types of jobs and the level of income that Black people broadly have. If you don't have a job that has benefits, then you're probably going to have to pay for healthcare out of pocket. And as we all know, that's going to be some exorbitant fee out of pocket. And if you're in that situation, then you don't have that type of money. So it's been even my own personal experience to avoid the doctor because you can't afford to pay the bill out of pocket.
And if I can add in my 2 cents, and this is just my personal, what I feel, but I, as an individual, feel that I am privileged just because I am of lighter skin tone. I am also a lot more fluent in English, whereas maybe other Spanish-speaking individuals, they cannot articulate their ideas in a way that they can be understood. Or just because of my skin tone, I will not immediately like raise somebody's blood level and all of a sudden, having to deal with that. But I think that also gives me an opportunity to be able to vouch for those people that cannot articulate their ideas. And a lot of this is going to have to be grassroots work. So right now, the guidelines for the companies that are employing essential workers, they are only guidelines. And I know there's been a few questions before that have been raised on like, what kind of penalties can there be? And unfortunately, until those guidelines become mandatory, there's not going to be a lot of penalties, and this is certainly not coming from the top down.
We have a couple questions from some listeners today. This first one is, why is it important that healthcare providers, healthcare facilities, laboratories, and local health jurisdictions report race or ethnicity for cases of COVID-19?
I think it's important to release that data, to have the demographic data, because then you understand who is getting it, and where to target the work on case, controlling, tracking cases, and really how to target the approach to treatment. So it's really critically important to have and I may not be happening. So a lot of people are seeing this demographic information, and they may be really having, there might be a lot of racism involved and stigma involved in how they view that data. So it's important that we contextualize that information. I have heard some people say that they think that certain racial groups are getting the infection more because they're not washing their hands. And this is definitely a racist view and a stigma. And we really need to, emphasize that it is these social determinants of where you work, what kind of exposures you have. That's what increases the chance of getting the virus. It's not lack of hygiene or those kinds of things. And I think some people do feel like, they worry that those kinds of views will propagate those kinds of racist views. And we really need to emphasize that those ideas are not true, and there should not be stigma associated with it.
This kind of ties into that, but the next question was, are the health disparities because of a genetic or environmental element?
So I wanted to piggyback on that, and that's something I'll also discuss, but I think the reason why it's important to discuss race is because it helps to unveil other issues that are correlated within that race. For instance, COVID tends to you have a higher morbidity rate if you have a systemic disease, high blood pressure, any type of heart disease, diabetes, any kidney diseases. Then you tend to understand that Black people are a population that tend to have a lot more of these systemic diseases. And it really comes down to why. Why do they have these kinds of issues? A recent study came out about the correlation between coronavirus and obesity. And then they correlated it with the fact that a lot of Black people have high BMIs and are obese. Why? And when you take the time to actually understand the reason why, then you can try to elicit change. For instance, there's a lot of obesity among Black populations because if you look in their neighborhoods, there are food deserts. There's no areas where they can get the appropriate produce that they need. So they have to live off of whatever they have that's around them, especially when a lot of times there's a lack of transportation and that lack of childcare, like I told you earlier. So if I have to travel 2 times further to get produce, then how am I going to pay for the transportation to get there? And then how am I going to bring all these groceries back? There's just so many things to consider. So I think food deserts are a huge thing that contribute to obesity, which is a comorbidity in regards to COVID. So all these things are all together, tied in together. Another thing is, having the ability to work out or have any form of recreation. A lot of these neighborhoods don't have areas where people can have freedom to work out or do things. And when we do decide to work out, we end up like Ahmed Aubrey, where you go for a run and you end up dead. So we have to take these things into consideration and understand that all of these things are correlated. So we really need to sit back and ask, why is race such a thing? Why is it something we ask? Because it's related to everything that's us, and it's related to everything that's America. So that would be my take on it.
Yeah, and I'd like to add to that as well. Research is incredibly important right now. We don't have we're just gaining ground with the coronavirus, but like Dr. Ashley Simpson was saying, we do know some things. And for example, right now, the New England Journal of Medicine have put out free articles on race in COVID. So anyone can Google New England Journal of Medicine articles on race and COVID. There's a lot of them from various physicians, but also just some beginning grounds of group studies. And we do know, for example, like in Louisiana, there was probably about 3,600 groups that were positive. Of that, 70% were hospitalized. 76% of those who are hospitalized were Black, and 70% died. So we do know there's some evidence that, it's not made up. We do know that there are higher rates of death from COVID amongst Africans specifically. And then we have to ask, well, why is that true? Genetically, we know there's lots of research that shows that they're not like a weaker species. That's been disproven. So then we have to look beyond that and say, well, what else could be causing this? And so we do know socioeconomics for any minorities, that's going to play a significant role. And that's why we do need to report race. So socioeconomics, we also know about what Dr. Simpson was saying was what we call like place-based factors. Like we keep hearing the word hot zones where COVID is really hot. And actually that can correlate to zip codes, and zip codes reveal some history of racial disparity, redlining, where actual neighborhoods were targeted, where African Americans didn't have access to other housing. They actually had to choose housing in a certain area. And in those areas, they've shown were marked hazardous. Like in New York, you'll see in the Brooklyn area, there was incinerators. So then toxins were being released into the environment. That wasn't changed until like 1991, 2000. Those 10 years were spent reforming that community. So, and then yes, food deserts, sometimes it's greater than 5 miles to access healthy food. All of these factors that we know are social determinants of health. And again, that's why we need to know race with positive COVIDs. And then another really interesting, really sad piece of information that we're discussing in medicine is this term that right now is just used, they call it weathering bodies. And of the African-American man, they're seeing actually a slightly more aged body. And they think it's due from chronic stress. Could be chronic discrimination where the body is taking this toll, and that affects the cardiovascular system. We know that. And so when you take COVID and you add it to these very vulnerable communities, we're going to see some really bad outcomes. And so we do need to do our due diligence to collect the right information so we can start targeting it. I did want to tie back to the other question that said, well, what can we do? And I think that we are eager to do something now. So we want to promote wearing masks, washing hands, making sure that information is translated to our communities well, and in the way that they understand it. Like even like a side note, the word mascara is like used to cover the whole face. And for a person who's working out in the sun, that's really hot. So like kubriboka, cover the mouth right here, not the whole face with the covering. That's like a simple terminology that we need to focus on. But in general, something that's more long-term is promoting our minority population to become physicians. Locally, the University of Washington has the Pipeline Project, where they're targeting youth to help reduce racial disparities and racial biases at an early age so that youth know that they can be physicians. And by doing so, we know that with other studies, African-American men, for example, are more likely to listen to another African-American physician and follow through with care because there's more trust. And I think one study even showed that there's a 19% increase to decrease that gap between white and Black. You can actually improve health in those ways. So there's lots of things that I think long-term that we can do. But right now, at least just talking about it, I think it would be very, very difficult if I were a farm worker right now and having to face all the different, just the different layers of having to work in a different power structure to speak up and say if, not everyone's wearing masks, if they're not being offered masks. So I know CVCH has done a great job as far as like the mobile clinic, doing more grassroots type things, but I'm just being aware with our community here locally that we value people over economics, and we value people more than our income. And so, yeah.
I think another thing to add on is that we also need to think about legislation and to really end health disparities. We need to think nationally also. So with the COVID-19 really highlighted the health disparities that were already present in America, and so this and Black and brown people are dying twice as much as white people due to COVID-19. So this has been a big call to action for medical communities. We really need to contact our local, state, and federal leaders for health systems reform. We need to increase better access, healthcare access to marginalized populations. We need to increase medical workforce diversity. It does make a difference. We need bias training in healthcare systems. These are the kind of things that a national reforms can do. And I know that there is some legislation that's in Congress, but we need our local leaders and national leaders to really support those issues.
Yeah, and to piggyback off of that, goes straight back into housing in regards to the policies that actually ended. So the CARES Act ended on July 31st, and that was where aid was provided, emergency aid was provided for housing. And as of July 31st, that ended, and now about 40% of the US population, or about 23 million people in the US, or families, can lose their homes. And when you look at something like that, those are people who are renting. And when we look at the renting demographic, it's predominantly African Americans who rent. And this is something that goes, again, back into history, whereas there's been redlining, like Kim has said earlier, and that it caused discrimination among where Black people could live. And in 1968, the Fair Housing Act was passed, and that was supposed to eliminate all disparities and all discrimination in regards to where you can live. However, now, with this law being passed, there are less Black people who own homes. More Black people owned homes when it was legal to discriminate than now. And when you look at that, you have to, again, ask yourself why, and ask yourself what happens when these people are getting evicted. Because as COVID is increasing, so is unemployment, and then evictions are happening. And when someone's evicted, especially if it's someone that you know, what are you going to do? You're going to invite them into your home. So now, how is anyone able to self-isolate or quarantine if there are so many people in one home? So, of course, we definitely need to continue to lobby and to be advocates for each other, to ensure that the government is going to protect us, not just in a healthcare aspect, but also in a housing aspect.
What would you answer to a response that this isn't a racial disparity, it's an economic disparity?
The two are linked and not separable. Race and economics are tied together. You can't separate them and make them two separate things that don't interfere with each other. Your race does not necessarily dictate your economic situation, but it plays a heavy influence on there. Just because you're Black doesn't mean you're automatically going to be poor. Just because you're white doesn't mean you're automatically going to be wealthy. But those things are things that influence where your socioeconomic status will be. And that's historical. That's, the point is you can't take them apart. They're one.
I know this statistic isn't COVID related, but it could be maybe crossed over that way. But I read that wealthy Black women are still like 2 times more likely to die in childbirth than low-income white women. Is that correct? And so that kind of, I guess, makes the low-income or the economic issue of that not
valid.
Yeah.
Mm-hmm. There have been some studies showing that even if you control for economics, minorities and people of color do tend to get a lower quality of care from some previous research.
Well, that's also because economics isn't something that's, just me. My my salary or how much money I make isn't just me. This is a generational thing that we're dealing with. There's generational wealth, there's generational knowledge. And with that being said, a lot of times when you do have some Black people who are successful or who do attain a certain amount of wealth, it's not something that has, not always, more often than not, well, I guess less often, you'll see that there's generational wealth or knowledge that's passed on within Black or Hispanic communities. A lot of times when people do attain a certain salary or certain wealth, they're probably one of the first in their generation. And that just goes back to history based off of slavery and how, Black people even came to America.
And I think it's also the access to social capital that me as a white man has, that Black people of color don't have as much of. that access. For example, the story that, Bill Gates, he didn't graduate from college and he did it, but he did. But his family was friends with Warren Buffett.
Exactly.
And so it's not like he just did it on his own. You have help, that access to internships and to programs that other folks do not have.
I'm sure everyone's heard, it's not what you know, it's who you know. That's exactly that. There are people who are less qualified, less educated, less everything, but they're well connected and they're able to get those high paying jobs where they don't have to do very much work and they get paid in dividends and they get the fancy treatment. And if you don't have those connections, then you don't have the access to that type of stuff and you have to work twice as hard to go half as far.
Yeah, and I think it's a fallacy and common misconception when a lot of people tend to say, I did this on my own. I pulled myself up from my own bootstraps, because no one can make it on their own. You had to make it with something. It just means that you didn't see value in how you were able to get to where you did. Not to, discredit anybody, but as you stated earlier, Bill Gates couldn't have been who he is without the networks and connections that he had. Therefore, he's not truly self-made. Of course, he put in the work like anyone else, but there are other things that helped him to become the person that he is. And a lot of times, minorities don't have that. They don't have that network. They don't have that education. They don't have the idea of, again, like home ownership. There's a lot of things that, we don't know. And another thing, is also credit. Credit's another thing that a lot of us struggle to get access to or even understand. Things that people would normally learn from their parents or grandparents. A lot of times we don't get that education.
I was just going to say, I do like to tell people too that the term pull yourself, or the phrase pull yourself up by your bootstraps, was actually coined to illustrate that it's something that can't be done. You can't, it's like they're saying, oh, that'd be like pulling yourself up by your own bootstraps. You can't do it. It's impossible. That's what was the point of it. So I think that point is lost on a lot of people today. And just like Dr. Simpson was saying, I do think a lot of people underestimate what other people have to go through. For example, I've had people tell me, well, just get a loan, or just ask your parents, or just do this or do that. And it's like, everybody doesn't have that safety net, whether I do or not. Everyone doesn't have that, so you can't just do this. It doesn't work the same way for everyone.
Speaking of community, another question was, what are some things we can ask specifically of our local city and county leaders to address the gaps?
I think that we need to ask to protect the most vulnerable ones, which are right now locally in North Central Washington, our agricultural workers. And a lot of the grassroots groups in our community are really targeting that population, try to help them.
Thank you. Is there any last thing that anyone would like to add? We are getting close to our hour in already. It went by fast.
I think it's great that we're having this discussion. Thank you for facilitating it.
Yeah.
I think it's been phenomenal to hear from all the panelists. We need to have a lot more of this. For anybody that might be interested in maybe participating, if they are healthy enough, maybe participating in some of those grassroots efforts that are being done, that are coming across our communities right now, such as supporting the agricultural workers. So if that is within your possibility to go ahead and either help organize, help participate, get the word out, please do so. I mean, this is something that we can all go ahead and do in a variety of different ways. So that's one way to go ahead and get started.
Since we're speaking about it, I do want to add that we had a comment in our chat to let us know that there is a rally for farm workers on August 15th at Memorial Park at 6 p.m. So that is one way that the community can show support by going to that rally on August 15th.
I thought it was great hearing from everyone, and I enjoyed all your responses.
Well, I am going to close us out with a few things. So just wanted to thank you all again for joining us for this Social Justice Community Forum series. Our next forum in this series is in partnership with Wenatchee River Institute, where we will be discussing racial disparities in access to nature. We will be announcing a date for that conversation soon. We are also partnering with North Central Regional Library for their event, NCRL Virtual Reads, with Ijeoma Oluo, author of So You Want to Talk About Race, on Tuesday, August 18th at 7 p.m. All NCRL Read events are free and open to the public. Events are held through Zoom, and an email will be sent with the Zoom link after you register. You can find the registration link through their Facebook event listing. If you have a topic you would like us to add to our series on social justice, please send us your suggestions through the comments and chats, or you can email us at info@wvmcc.org. Again, that's info@wvmcc.org. Thank you again to all our panelists and listeners for your participation today. And we hope you'll be able to join us again as we continue this conversation.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you.
Thank you.